Good evening, friends, and welcome back to the Thursday teaching sessions being brought to you live from IAP-Sion Hospital, Mumbai. As you all know, we were doing these sessions online during the COVID period and restarted the physical clinics from end of September. And thanks to the efforts of everybody, including Dr. Radha Madam, the current head of pediatrics of pediatric department, LTMMC Sion Hospital, we are now able to bring these clinics live webcast to everyone. We also thank Alchem Alpha Division for their educational grant to facilitate the webcast of these clinics. These clinics can be viewed on www.clinicalpediatrics.in or the DIAP page, whichever you choose to, and they will be archived there for subsequent viewing also. We've changed the format slightly, so now we will be doing one long case per clinic, and there will be a short discussion on any topic which can be useful to students, which could be useful in theory as well as in the practicals. So today we start with one such topic first, and that is approach to immunodeficiency, and Dr. Amdekar sir will be dealing with that. So we start with that first, followed by the case presentation. Amdekar sir.
Good evening, friends. The idea is not to give all details of how to approach immune deficiency, but in next 15-20 minutes, I want to give you an overview of what is immune deficiency, how do we go about in clinical practice, and how much can we go further in terms of management. The details, of course, one can always read, but this gives you an idea how to approach the problem in particular. I think what is important is we must understand the basics. For everything to understand clearly, if we know basics, I think a lot of things work well. Just to kind of, again, go through some things very simple. You have an innate immunity, okay, and you all know there are anatomical barriers, there are functional barriers of different kinds, and of course there are also the immune barriers, okay, the immune cells which are part of innate immunity, and we all know this very, very well. I think macrophages produce the TNF alpha, the natural killer cells produce the interferon gamma, and there is a complement system. All this is part of innate. And then, of course, you have an adaptive immunity, and that is largely T cell. You have a CD4 helper cells and a CD8 cytotoxic cells are called killer cells. Please make a note that this killer cell is different than natural killer cells. Okay. And of course, you have a B cell. Through antibodies, you have largely CD19, CD20. Make a note that these are not only the CDs that these cell markers have, but these are the most common ones that we all need to look at even when it comes to investigations. I think CD refers to the cluster of differentiation or classification determinants. And what is this based on? The immune markers on the cell surface. So these are the immune markers, and there are many more. But the most important is what we minimally must know about it. And there are many more specific markers which are used for a specific diagnostic purpose. And when you know this much, then we quickly look at how does one get to use all this. For example, antigen recognition is done by a pattern recognition receptors. There are multiples of them. In rheumatology, the clinicians talk about pattern recognition. How is the patient presenting in what kind of pattern? And that gives you a probable clinical diagnosis. These are something similar because each organism has some kind of a pattern which these pattern recognition receptors pick up toll-like receptors are just one of them. They are largely in the intestines, but there are multiple such subtypes of pattern recognition receptors. Once you know that, then I think they interact with immune cells and processing cells. Their job is first to identify, recognize an intruder. Once they recognize that, then they interact with immune cells and the processing cell, because this needs to be processed. And which are these cells? Largely the B cell, the macrophages, and dendrites. And what is their job? They capture the antigen. So you can imagine one recognizes it, the next group of cells captures it, and then processes it. It cannot be dealt just like that. So it has to be broken into small peptides, and then they migrate to a lymphatic system where they would activate a very antigen-specific T cells. Somebody has given a nice, simple description that if you go to the airport, the first thing you are just screened. Okay, recognition. They suspect, they pass on to somebody senior, and when he further processes it, they would call all the police and round you up. Now, exactly this happens even in real practice. So this is one that you need to do. You need to do something a little more about basic immunology, like an HLA, which we often talk of, human leukocyte antigen. Again, the protein that helps differentiate from self and foreign. And this is the most important part of the immunology. And then the complement system, okay, which is largely proteins produced by the liver. These are inert molecules. They are not active, but they need to be activated. And then they develop into a cascade of several proteins, one after another, largely in a classical pathway, which is the antigen-antibody complex dependent, or alternate pathway which is quite independent and triggered by a C3. This is the first response to infection. Okay, and each one of these plays a role ultimately. When something is going wrong, it's not just the one, but that's one the primary defect, and thereafter everybody starts not getting into the cooperative movement of catching the thief. And then if you see, we know this very well, that polysaccharide antigens are very powerful, but they cannot be used in the first 2 years of life. They have to be made T cell dependent, and that's why we do conjugation. And you know how today the typhoid, pneumococcal mini can be even given very early in the course of infancy. I think a word about primary and secondary immune deficiency. When you suspect immune deficiency, it may not be primary fault, maybe genetically determined. It could be secondary to varieties of things, and common ones are PM, malignancies of different kind, drugs. Okay, for example, chemotherapeutic drugs. You get into immune suppression, and therefore, when you consider an immune deficiency, you also keep in mind whether this is secondary to some disease or drugs that are already on, and then it becomes not so difficult to manage or investigate them. And I think what is important to know in immunology now, that things have improved so much in understanding that somebody may be selectively susceptible to one type of infection, and he can deal very well with all other types of infection. This is very selective immune deficiency, and it's worth keeping that in mind also. Not very common, surely, but today we do have case reports where a child is immunocompetent in usual way, but selectively seems to be not be able to kind of take care of a specific infection. And the typical Mendelian susceptibility to mycobacterial diseases is a classical example where a very benign and easy-looking atypical mycobacteria also cause of severe disease. Now this is where you have a selective kind of deficiency. So keep all this in mind when you kind of approach that. Now having given these basics, let me come to when do you suspect an immune deficiency? And I think the most important word is the unusual presentation. Okay, now add to that the severity, the persistent, or the recurrent. And therefore the spur is the mnemonic. Okay, but most important part is, does every severe, persistent or recurrent problem is an immune deficiency? No. It has to be unusual. And therefore unusual is the word. And then now we see how recurrent bacterial infection, recurrent viral infections are common. But recurrent bacterial infection could be an IgG deficiency, but also keep in mind that if you have a recurrent pneumonia only in the same lobe, it may not be immune deficiency, it could be a local malformation, which is likely to form a nidus 2 infection. There could be other causes like a CF, for example, or an immotile cilia, for example. Multiple other causes other than immune deficiency also cause a recurrent bacterial infection. However, there is a small difference. What is the age of presentation? What is the rest of the syndrome along with that? Are there multiple sites of infections or is the same site? And I think we give a credence to all of that. But the point is that recurrent bacterial infection is not accepted as just common. But look at, you have a upper respiratory allergy, allergic rhinitis, rhinosinusitis, you are likely to get secondary infection because you have a retained secretions in the sinuses. So these are the things that you always keep in mind before you jump to say it must be that. What about severity? I recall a 5-month-old baby who was all right till early morning when he got up and passed few loose stools, and in the next 4 hours the child was admitted with severe shock. What a very severe progression. Okay, unusual? Yes, if that was so, then this would be again some kind of an hypogammaglobulinemia, whatever. That is the next thing to look for. But here we are looking at how. Then unusual progression, for example, the wound doesn't heal at all, or there is a delayed separation of the cord, for example. Now this could mean that there is some neutrophil defect. Similarly, I said that if multiple organs are involved in infection, you are more certain that it's some general immune deficiency. But there are exceptions as well, and IgA is a classical example where largely it's restricted to a pulmonary infection. But what is unusual? Chronic progressive. Each episode is worsening and each episode is getting more severe, and ultimately these children by the end of the first decade come with a chronic respiratory failure. So even IgA could do that. And you know how the spectrum of event, the IgA, for example, IgA deficiency may present first time with an ataxia, and nobody has looked at the telangiectasia in the eye. So these are the issues that can manifest for the first time at any time. Then you have, of course, recurrent abscesses, soft tissue, liver, lung, which is unusual. This could be certainly some kind of a phagocytic defect. If you hit an unusual organism that is not expected to be there, then of course you start, like an aspergillosis, an unusual complication to live vaccine, BCGitis, non-healing ulcer. Well, the ulcer is not healing, but there is no pus formation at all. So severe inflammation, polyvascular leukocytosis, but no pus, typical leukocyte adhesion defect. And finally, the recurrent granulomas, soft tissue, lung, liver, whatever, I already said, it's a chronic glomerulomatous disease. Now, these are the ways we start suspecting, but the word unusual, and every time you argue or write an answer, you say unusual is the key word. And whatever happens unusual is likely to be that. Now, of course, if somebody has just failure to thrive, you don't know what is it. You have tonsil, thymus, lymph nodes are absent, that's one clue. You have a premature loss of teeth or sometimes a double set of teeth. For example, hyper IgE with a double set of teeth. How simple examination can give you a probable final diagnosis, not always true. Eczema, of course, partial albinism, then unexpected purpura. We know that Wiskott-Aldrich, for example, could be a part of immune deficiency but may manifest with purpura, and you would say, oh, this is an immune-mediated, okay, ITP, and you might have to look more carefully to see whether there is any clue to an immune deficiency. Similarly, a herpes zoster, which is multi-segment. Normally the herpes zoster is just unisegment, which gives you an idea where something is going wrong. Recurrent genital ulcers. But what is more important is all these immune deficiencies are a part of immunological disorders. And we must have discussed this again and again, that all these disorders really overlap with each other. If you see mouth ulcers, you might start wondering whether this is going to be an SOGIA. You are looking for one of those rheumatological disorders. It could as well be immune deficiency also, because immunological, all three components overlap each other. You have an immunodeficiency, you have an immunoreactive, and you have an immunodysregulated, that is malignancy. And that's why you have an HIV, yes, AIDS, with even the Burkitt's lymphoma. So you have a malignancy with immune deficiency. So all this combined together. And I think what is more important is, if self is eliminated, as again non-self is tolerated, these are the basic problems with immunology. That I can't tolerate my own organ, or I don't care if somebody else is intruder in my body. Both are the evidences of some immunological dysfunctions. Having said this, we have seen where the clinician suspects immune deficiency by the word unusual, and then you add the whole list of unusual occurrence, presentation, complications, whatever. But there are many other ways of further fine-tuning the probable clinical diagnosis. How do you do that? One is age of onset. Now, if it's early infancy, in the first 2, 3, 4 months of age, very likely it's an SCID, or it could be DJORG or Viscotaltridge, one of the T-cell defects which come up very early. If it happens late in the infancy, a second half typically, then you may have a B-cell deficiency or a cyclical neutropenia which comes at that age. And largely, up to that time, the maternal transfer of IgG mostly takes care. But that will not last long. That will go down gradually, and the patient may present at 4 months of age, where you pick up some IgG, which is maternally transmitted, but that's not large enough as a response to infection, and therefore you have typically a later in infancy. Now, beyond infancy, you start seeing a complement deficiencies. Then later in childhood, you get those phagocytic defect or a CGD. Generally, all this happens under 5 years of age. And then, of course, acquired that we talk of can occur at any age. So age of onset might give you an idea. Today we know that every disease has a spectrum. And if you further break it down genetically, then you find that, yes, some mutations may present a little later than earlier, but for all of us as non-immunologists, general pediatrician, this is the way to go about, and most of the time you will be right. What about family history? Of course, important. Some are sex-linked recessive, many are autosomal recessive. We know all that, and therefore a detailed history of what's happening in the family, early deaths, is an important issue. And then, of course, based on organisms. For example, if you're suspecting a B cell, then you are largely looking at the intracellular organisms. If you're looking at T cell, then you're looking at viruses, TB, fungi. Then if you have a phagocytic defect, typically a staph, nocardia, aspergillosis. So these are the ways you start, and of course complement can look like B cell, Neisseria plus. So the type of organism that you got also might give you an idea which kind of problem you may be dealing with. Having said how does a clinician suspect this, let me talk about how do you basically screen the child who is suspected clinically based on all this. And what do you do really? The first is, of course, the CBC. And here you know that cyclical neutropenia can be picked up, counts are low, Chediak Higashi, for example, lymphocyte count low, T-cell defects, low platelets, Viscotaltridge, eosinophilia and high serum IgE is classically seen in hyper IgE syndrome. So CBC also may give you some idea, not every time, and we already said earlier that and typical LAD has a very high neutrophilic leukocytosis but no pus formation at all. If there is no clue on CBC, then we go further and we do an all immunoglobulins, and we of course do a CD19, CD20, and then you do CD4, CD8. There are other ways of looking at antibodies. For example, a blood group. A child of group A must have an anti-B antibodies. Okay, at least we know that that kind of antibodies are going right. And you might also look at if he has had a DT toxoid, then has he built up an IgG to that toxoid? And I think these may be very simple even without having a very detailed investigation. Of course, T cell, the lymphocyte count, CD4, CD8, a MAN2 and BCG response is not a very ideal thing now for varieties of reasons, epidemiological, but yes, that's also a T cell kind. What about ADA, the adenase deaminase? We have learned this is a useless test for diagnosis of TB because it's very non-specific. But if ADA is very low or absent, that might give you an idea that there could be something wrong. And then, of course, one can today do a FISH and see what kind of mutations you are looking for. If you look at hyper IgE, then IgG is normal, but if you look at hyper IgM, then all are involved, all are low. So some of these tests that are available mostly everywhere, I think we need to know them and we need to do them as a screening test. And if there is no clue, even after that, that means you have looked at CBC, B cell, T cell, and then you are looking for complement. CH50 is a screening test, and you are looking also at NBT. NBT is now given up. And you have a better test, that is the DHR test, and that is replaced NBT test, and this of course you could do. Now this is where I was talking about, there are specific markers which might tell you the specific probable diagnosis, and one of them is to look at CD18 for a leukocyte addition defect. This is just to make you aware that it's not only CD4, CD8 or CD19, CD20. For immunology, there are many other markers, and I don't think we need to go into that at all. I have not dealt with management at all for two reasons. That management today is really starts with early diagnosis, and we have discussed that part. And when it comes to management, we all know that it's against infection, so you take care of infection, so you must have a good bacteriology, good antibiotic cover, long-term antibiotics, preventive antibiotics. But finally today, that majority of the such diseases, and not only immune deficiency but many more, are today curable with stem cell transplant. So the point is, as a general pediatrician, we must know how to pick it up early, how to screen early, and how to hand it over with a reasonable confirmation. It's some immune deficiency. What more, what kind, what management, we must leave it to that. I thought this is an overview, and for every Thursday, we will have such small overviews so that it helps you to write an answer in theory as well as approach a clinical practice, right? Good.
You have any questions on this? Any doubts, anything you want to ask about this? Okay. Anything online, Sridhar? No. Okay. Fine. So that was the first part of today's Thursday clinic. Now we will have the case presentation by Dr. Mamta. So Dr. Mamta.
Oh, good evening everyone, respected teachers. I am Dr. Mamta from IAP-Sion Hospital. So I'll be starting with my case. My patient is 3-year-old female child, third by birth order, born of non-consanguineous marriage, resident of Dharavi, brought by parents with complaints of irritability since 3 months, fatigability and decreased appetite since 3 months, and child looking pale since 1 month. So child was apparently alright 3 months ago when parents noticed child to be irritable in the form of excessive crying, throwing tantrums and excessive anger towards siblings. Parents also noticed that child had decreased appetite since 3 months, with child eating only half of the previous amount, but this was not associated with feelings of nausea or episodes of vomiting or abdomen. During home visits of Anganwadi worker, it was told that to parents that child was pale and would require to visit doctor for some blood investigation. On inquiry, the parents have noticed that child being increasingly pale since the last month, but did not think child was unwell. So child was taken to private practitioner and some blood investigations were done. Child was told to have low hemoglobin and was referred to our center. Child was worked up and found to have low hemoglobin and was transfused with blood on 3 occasions, 12 hours apart. On day 4 of admission, child complained of headache and 2 to 3 episodes of vomiting. Headache was mainly occipital and moderate, relieving on medication. Vomiting 2 to 3 episodes, non-projectile vomiting containing fluid. Parents were told that child had high blood pressure and could have some infection in the brain, followed by lumbar puncture and some neuroimaging was done. Child was shifted to PICU. In the PICU, child was having signs of raised ICT and developed paucity of the movements in right upper limb and lower limb. Child was intubated in view of dropping sensorium. Repeated neuroimaging was done and parents were informed that there was some blood collection in the brain and child might need neurosurgical intervention. So there is no history of pica, no history of bleeding manifestations, no history of blood transfusion, no history of blood transfusion in family or no history of splenectomy in the family members, no history of hematological disease in family, no history of family history of gallstones, no history of easy bruisability, no history of passing worms in stool, no history of yellowish discoloration of eyes, no history of trauma, no history of Cox contact. So provisionally from history, the differential are hematological disorders like hemoglobinopathies, mostly sickle cell anemia. Second is coagulopathies, structural AV malformations, and chronic infective etiologies like TBM.
Okay, we'll go back. Okay. So if you had these chief complaints, what would be your thought on each one of them? So 3-year-old girl brought with irritability for the last 3 months. So what would be your thoughts?
Irritability since a long duration, 3 months, it could be because of something like iron deficiency anemia or anemia basically, because one of the symptoms of anemia is irritability. So that would be one.
Okay, so iron deficiency is one. We'll discuss that. Anything else?
Sir, some chronic CNS pathology.
Okay, so what kind of chronic
Like infection.
CNS pathology?
Like infection.
So infections in the CNS, are they usually chronic? Which infection
like
are
TB,
we? Yeah, so is TB chronic in the CNS? It is, you can say at the most subacute, right? So what I mean is that will a CNS tuberculosis present with 3 months of irritability and then some come with some other manifestations? Will you have a CNS TB like that? No. So not chronic, so at the most subacute. But what chronic CNS thing may come with irritability? Roughly 3 months period. So what happens if there is raised ICP? How will a child with raised ICP who's 3-year-old slowly progressive raised ICP. How will that child present?
Child will be irritable, he'll present with head banging, and parents will notice this change in behavior over a period of time.
So point is that headache is not very obvious in a 3-year-old. So it may be manifest as irritability. Of course, you'll have to get into a lot of details. If it is raised ICP, it should be associated with vomiting also intermittently. It should be progressive irritability over those 3 months, all those issues. But what I'm trying to say is, one is you think of chronic or rather CNS raised ICP as a possibility, not so much as CNS infection. What else? What else can be irritability? So basic undergraduate causes of irritability in children. One you said is CNS. Can it be some electrolyte disturbance in CNS? Can any CNS electrolyte disturbances cause irritability?
So hypernatremia.
Hypo or hyper?
Hyper.
So what does hypo cause?
Sir, hypo if below 120 is more likely to cause seizures.
Okay, even hyper can cause seizures. So hypernatremia is more associated with irritability, hyponatremia with lethargy and drowsiness. Okay, classically. But again, 3 months is something very difficult with either hypo or hyper. Sir?
I think what will be more important is to know origin, duration, progress. Okay, we learned it in undergraduate. We have not heard what is the origin, duration, progress. We know it's for 3 months. But has the progress been worsening, same, improving, or up and down? We haven't heard that.
Actually, it's worsening. Parents are complaining it's worsening.
No, speak in the mic.
Actually, it's worsening. Parents are
It's
complaining.
worsening.
Yeah.
Okay, worsening over 3 months.
Yeah.
So add a word, slowly worsening. Okay. So now it started all of a sudden. It was not so bad. If you were there in the first few days, what would you have said? You would have said, is it pain or no pain? That's the first group. And where is the pain in the 3 months? You would have made every limb move to be sure that he has. Okay, a pain in the clavicle may not be easy to make out. You may have to move the limb every way. And therefore pain is the commonest cause of. We are saying about first few days, how I would have gone on. Pain being the common. Could the pain be in the intestine? Could it be an intestinal colic? So go further and say that if it's irritability with pain, has it been episodic, recurrent, or continuous? Okay, that I would have left out a colicky pain wherever, ureter, bile duct, okay, intestine, all that would have been out. And any physical injury, etc. No. Could it be an ear pain? How do you pick up an ear pain on the history?
So in this case the child is already 3 years old, so can actually point towards one of the ear.
There would be itching over the ear and
Okay. The most important thing is that yes.
It will be unilateral.
All right. But most important is, why should there be an earache? It has to go through the nose there, and there has to be a cold. Okay, whether the child is able to make it or not is different. So the rest of the pain we can make out, the colicky pain we can make out, ear pain we can make out. Okay, but what about headache? Can we make out a headache on the history? We are in the first week. And in this child, we would have said in the first week, doesn't look like physical injury, trauma, doesn't look like colicky pain, doesn't look like ear pain. Then I want to know whether it's a headache. And 3-year-old cannot point to the head. As Rohit said, you can bang the head, but even that may not be common. Irritability else. How do you pick up a headache? In a young child, generally 4 or 5 years is the age where he can point to a headache. Till then he may not. How do you pick up that? And therefore, two things. Does he wake up from sleep with crying? Okay, more likely. Okay. Then does he have vomiting? More likely. So you get all those details. Not every time the answer would come, but we have to make an attempt to get an answer. Suppose now I come to conclusion that there is no pain. Then what is painless irritability? And painless irritability is largely a metabolic problem. Hypernatremia, you said, metabolic acidosis maybe. Okay, so we start looking at that. Now this is the way would. Most of those metabolic problems are acute. This is gradually worsening. So we come to a conclusion, this could have been a gradually worsening headache. But this is the way to think about it. Okay, now you are coming on the first 1 month of headache. Okay, you have said that is gradually worsening headache. Now tell me what must be the cause of this headache. Now tell me the anatomy of this headache. Where is the intracranial, where? Migraine?
So
It's a headache. 1 month, where is the problem?
very early presentation, and we'll have to ask for triggers whether child
No, but
reacts.
what is the characteristic of migraine?
Unilateral.
Use one adjective which is a must for migraine.
Unilateral throbbing.
No, unilateral is not must. In children, we can have bilateral headaches as migraine.
It will not be continuous, it will be recurrent, or it can come down.
Yeah, so what is that one word you will use for migraine? Episodic.
Episode.
Okay.
This is not episodic. This is not migraine. We're just trying. I don't know whether migraine becomes over. Maybe not. Okay, I am not aware. But the point is, yes, this is not. This is slowly progressive. Where is the anatomy? So we already said raised ICT. Okay, that is headache. Where is this raised ICT coming from? Slowly progressive, so mass. Not infection, TB, this, that, no. There is a mass. Slowly progressive worsening is a mass, tumor. Where must this tumor be now? Anatomy. Only on the history. We are still at 1 month of irritability, and now add what she said further, tiredness and anemia, which tells you etiology, but I am asking the anatomy. Where is the anatomy of this tumor intracranial? So how do you describe by history the anatomy of a brain tumor?
So let's make it little easy. So which SOLs will have many other neurological signs? Do you know of any SOL which has many other neurological symptoms and signs?
How does a tuberculoma or a neurocystic circus present?
Seizure.
Seizure.
Where are they placed?
Where is the anatomy?
Parenchyma.
Supratentorial.
Supratentorial, infratentorial. First make a difference. Okay. This child has no seizure so far. Okay. Could it be infratentorial?
Some cerebellar signs could be there, infratentorial.
Very good. Infratentorial compartment is so crowded that you have a cerebellum, the midbrain, the pons, the medulla, multiple cranial nerves. You will have many others. Okay. So this is neither supratentorial or infratentorial. What does it mean? So this is likely to be outside the brain, in the coverings of the brain. Okay. He will have something to come up as it goes on increasing. So anatomy is somewhere in the meninges. Okay. Now tell me, is it subdural, subarachnoid? Where is it? Or extradural? Even history can make that out.
Could be subarachnoid because that irritability is progressive, so could be blocking the flow of the CSF, subarachnoid mass would be.
So the irritability is due to raised ICP, right? So when will it cause raised ICP? When it is dura is the tough membrane, right? So it should be under or above to press to cause raised ICP. What do you think?
If it's under the meninges in a parenchyma, the presentation is devastating. Okay, so this has to be out. Okay, so we know anatomy, possibly. Why did we get to that anatomy? Because there was nothing in terms of seizure, and if it's gradually increasing, I would expect seizure to come fairly early. But it has not come so far. So now we have an anatomy that. Now add tiredness and pallor. What does that mean? You can see that. You can see that. What does that mean?
So if we are considering a tumor, then any intratumoral bleed we can suspect.
Okay. Do you think it's a bleed in an already existing tumor or a bleeder by itself? You get the difference? I have a tumor which suddenly bleeds because it's a vascular tumor. Or the other one is, it is bleeding, a bleeder only.
So it is likely to be a tumor which has started bleeding because the presentation has come over this period of time.
Yes, if it would have been an acute bleed, then some acute symptoms would be there, like headache and drop in sensorium or something. That would suggest, because the history here is of progressive fatigability and pallor. So something that is chronically bleeding would cause these symptoms rather than an acute bleed.
I think if there is a tumor and one day it starts bleeding, it's an acute onset of a problem. This is not acute. What are the symptoms? Symptoms of progressive anemia, tiredness, which means the bleeding is occurring slowly, which means it is a hematoma, slowly oozing. Okay, why should it ooze slowly? So does an arterial injury oozes slowly or a venous injury oozes slowly?
Which one is more likely to ooze slowly?
So venous.
Very good.
Okay.
Very good.
So this must be a venous bleed. Where is the difference between subdural and extradural? Extradural is an arterial bleed, subdural is a venous bleed, mostly. So now we have almost come to an anatomy of a subdural hematoma. Now that's gradually increasing, so one fine day that caused a seizure because it's now almost abating the cortex as well. See how funny it is that we started with a correct thought process and arrived at anatomy, pathology, possible etiology. Now, last thing, why did it bleed? No history of trauma. No, trauma is one cause of subdural hematoma. Okay. When a baby is born with a forceps, there could be a trauma, and it takes about 2 months for a baby to come with a seizure, focal, and anemia, because it takes time to build. Here there is no trauma, then what must be the cause? Give a thought. Okay, we may be absolutely wrong, doesn't matter. Okay, in this clinic we want you to learn how to think clinically. Okay.
What are the other possibilities that can bleed slowly or reasons for bleeding slowly?
So coagulopathies, bleeding disorders.
Okay. So now possible, but think back and suppose we have any coagulopathy or a bleeding disorder, and when they have an intracranial bleed, is it a slow, long-standing bleed, or is it a sudden big bleed?
It will be a sudden bleed and not be isolated as well. It will be a sudden bleed and it will not come as only intracranial bleed.
Yeah. So there will be many other areas that are involved, right? And almost never is it as the first CNS manifestation. In which situation do you get a CNS bleed as a early manifestation? In which bleeding disorders?
At 1 month of
Hemorrhagic disease of the newborn, no? You may sometimes...
Vitamin K, late manifestation intracranial bleed.
Okay. So barring that, it's not a usual common thing for a coagulopathy, right? Now, we were told that this child was given some 2-3 transfusions on admission, right? So now a little different part also to be thought of, that can this child bleed so much to get so pale that the child needs 3 transfusions? What I mean is, did we come down from say 11 or 12 to whatever level, or was this child originally also pale? What do you think?
Because her history is also suggestive, not eating properly.
Yeah, but not eating properly only now in these 3 months or even before that?
Since 3 months only.
Okay, since 3 months only. So, but that means it's a rapidly progressive anemia, no? So would you think of one part is what we have discussed with sir just now. Would you think of any other situation or any other combination of events? You have irritability, you have progressive anemia, you have constitutional symptoms like not eating, etc. What else would you think of? Of course, details in the history would fetch it out, but what else would you think of? Can it be a primary hematological disorder? What?
So, but the history is saying that the child was absolutely all right before these 3 months. So it's less likely to be hematological in cause. The presentation would have been early and the child would not have been doing well in the last 3 years also.
So you're talking from a point of view of anemia, less likely to be. I'm asking which hematological disorder causes irritability? Can you have some hematological disorder causing irritability?
So sickle cell.
Okay, why? Pain. Now again, same logic. In sickle, the pain is low grade, long standing or sudden acute pain?
Sudden and acute.
So they are called painful crisis. So that is not irritability, right? Can it be an infiltrative disorder like leukemia? Irritability, progressive pallor, and not eating constitutional symptoms.
So it could be a possibility because the leukemia infiltrating the marrow and then causing anemia. So that could lead to progressive pallor and irritability.
So, but what are the things that don't fit in?
In a case of leukemia, pallor would come a little late and other signs like easy bruisability and infections or bone pains would have come earlier.
Okay, what else?
Weight loss and...
Weight loss, generally in children, leukemias are fast, so weight loss may not be perceived. What else? Fever. So fever is very important, no? So again, what we are just trying to do is make you think of the patterns, but then say, okay, this is not there, so this is less likely, more likely, etc.
I think if you look at anemia, then this is a chronic anemia. Chronic anemia is deficiency, hemolytic or bone marrow. Okay. You should have asked for an abdominal distension also. Okay, 3 months story, progressive anemia. If the mother would have said, no abdominal distension, then you have a chronic progressive anemia without hepatosplenomegaly. So you narrow down to deficiency anemia or a bone marrow aplasia. Bone marrow aplasia, generally sick child, maybe also other cell lines, maybe purpura, etc. So this must be deficiency anemia. But you said that the child was all right 3 months ago. So maybe the deficiency anemia could have been mild, nutritional, but this is progressive fast. So which is fastly progressive deficiency anemia? You get the point? Iron deficiency is not fastly worsening. This is fastly worsening. Okay. So which deficiency anemia is fastly worsening? It's deficiency anemia. And the answer is the bleeder. Common bleeder intestinal. You have a polyps bleeding, a microscopic stool check is not done. There is no visible blood, but he is losing. Hookworm anemia, chronic deficiency anemia, cause bleeding. So slow bleeding. We are talking about slow bleeding intracranially, perfectly matching. So this is a deficiency anemia caused by slow chronic oozing of blood. And because it's slow chronic oozing, it's venous. Because we know it's subdural, and diagnosis is a subdural hematoma, right? Trauma may have been missed. Okay. Earlier days, I recall, maybe I'm talking about 50 years ago, it was not uncommon for small infant or a toddler to be thrown up and caught. And it led to shaken baby syndrome because the brain is loosely existing in the intracranial, in the cranium, and there is a small gap, so that you shake the head vigorously, the brain parenchyma abuts against the skull bone and may cause bleeding. Okay, trauma might have been missed, we don't know. Okay, unless there was a small malformation that oozed slowly. Yes, that's another possibility.
So now we'll just discuss whatever differentials you have thought of after history. So one sec. So this after admission, after blood transfusions, on day 4 the child deteriorated with complaint of headache and vomiting, and parents were told that the child had high blood pressure. Okay. So now, can you just give your thoughts on this situation? What does this headache, vomiting mean? Raised ICP. What about that high blood pressure? So it is the cause of raised ICT or the effect of raised ICT?
It's the effect of raised ICT.
How are you sure?
Because so after, along with the headache and vomiting, then the child was found to have high blood pressure. So the sign has come with the symptoms. So it's most likely an effect.
Take the mic always to answer so that everybody can hear. There are a lot of online viewers also. Yeah.
The raised BP could have caused bleed acutely, and that could have deteriorated the child further, causing headache, vomiting, and symptoms of raised.
Okay. So my first question is that how do you differentiate between raised ICP causing a intracranial bleed or a raised BP causing a intracranial raised ICP versus raised ICP causing raised BP? How do you differentiate between the two? So first tell me simple thing. Which of these BPs will be higher? The original hypertension or the reactionary hypertension? Which one will be higher?
The original hypertension.
Original hypertension, right? Now reactionary hypertension, reactionary to raised ICP. Why does it happen?
To
To maintain cerebral perfusion pressure.
To maintain cerebral perfusion pressure. So how much do you need the BP to go up to maintain cerebral perfusion pressure? So usually it will be just at the 95th centile or a little above that. It won't be sky high. You don't need that high BP to maintain cerebral perfusion pressure. So you have to also go by what is your reading. So if your reading is sky high, it has to be primarily hypertension. And if it is just a little elevated, it could be compensatory to the raised ICP, right? Now, as far as original symptoms are concerned, they may or may not be there. So there are some hypertensions which can be silent, and they will first manifest with whatever complication they can do, right? But in children, is hypertension originally primary or secondary? Somebody has high BP, forget the complication. That high BP is commonly primary or secondary?
Secondary.
Very good. Secondary to what? Renal. So you should fish for the history of that renal disease, which might tell you that this child was unwell and you expect some hypertension, etc. You got my point?
Yes.
Okay. Now, okay, so just discuss your differentials.
Why did he suddenly go down? Because we are talking about a slow bleed occurring over 3 months. Why did this cell suddenly go down? You mean further bleeding occurred all of a sudden? No, it's slowly bleeding already, no? Why should suddenly it starts pouring more? No, unlikely. So what must have happened? So now the hematoma has grown so big that it's causing a mass effect. And this is one area where a unilateral disease may cause a generalized encephalopathy. Okay, it will affect the other hemisphere also. It will cause herniation. It will cause multiple things. Okay, so some complications are occurring because of its progressive large size. That's why he deteriorated. He was waiting to deteriorate. Okay, it's going on for the last 3 months. And herniation syndromes, typically an uncle herniation, okay, would affect multiple ways of that. In the clinical finding, we might find some evidence of such problem.
Okay, so why do you suggest that this could be a hemoglobinopathy? Whatever are your points for, and if you think there are any points against.
Sir,
Speak in the mic. Huh?
Sir, positive points are she came with complaints of severe pallor, but there was no history of any bleeding manifestations. Bleeding.
Correct, but severe pallor could just be iron deficiency, no? So why hemoglobinopathy? What do you all feel? You would have said hemoglobinopathy as a TD here. If so, why? If no, why?
Yeah, so in the comment box, we have a lot of comments from Palni Raman. And right in the beginning, he had said, congratulated you on a beautiful presentation. So crisp and so good, and we all do agree on that. He has said that the hypertension is a terminal event when you are coning. So any comments on that? The hypertension that we were discussing as primary and secondary is terminal in coning.
I don't know if it's terminal in coning. My understanding is it's a compensatory mechanism to maintain CPP.
Yeah, that's why he said it's a mild hypertension. Okay. And all that is also nature's attempt as a last ditch to save the perfusion pressure. So you almost never see Cushing's triad in clinical practice. You also rarely see in an intensive care practice. So it's the last nature's attempt to save life. So we should not really much anticipate, but mild rise, as he said, little 95th centile or little more is accepted, but that's hardly a hypertension that way.
Because you also get that element of bradycardia. So it's that bradycardia and the hypertension that forms the triad.
And irregular respiration. Okay.
Something to do with the center, the medullary center.
So, any thoughts on hemoglobinopathy? Yes, no? Particularly, why have you put sickle cell as a possibility? Means,
Because initially we were thinking of thalassemia, but it won't present at this age.
okay, fine, go on.
So
Now,
negative point is patient didn't come in crisis.
okay. Well, okay, coagulopathy you said as a cause of the bleeding, but coagulopathy as in one of the congenital or congenital coagulation disorders.
Yes, sir.
Okay. Structural AV malformation, points for and against?
So structural AV malformation, then again the history is a very chronic one. A structural AV malformation causing a bleed would present acutely.
Right. So what we have heard and seen cases of structural AV malformations are sudden bleeds. Till that point they were silent and they were not really presenting as a mass effect, so to say. Okay. What about chronic infective etiologies like TBM? I mean, we are just discussing. It is good of her that she has put 3-4 differentials so that we can discuss. So it's just a thought process. So would you have thought of TBM when this child deteriorated or before this child deteriorated? First discuss before this child deteriorated and then after the deterioration.
So there's no history of weight loss or fever in this child.
So weight loss, as we said, has to be very marked to be appreciated by parents. And in a 3-year-old whose original weight suppose is 12-13 kilos, 1 kilo difference, they may not be easily making it out. So don't bank on that. Okay, fever, yes, I agree. What else?
Sir, the age is very early for considering TB meningitis, and we'll also have to look for any cognitive decline, seizures, and the movements of the body. I mean, here we only have irritability as the manifestation.
So, I mean, TBM can occur at any age, but as we discussed a while earlier, you wouldn't have irritability going on for 3 months before other neurological manifestations come up. It would be 10, 15, 20-day story at the most, right? So that is a point against TBM. And of course, the deterioration was very sudden. So after deterioration, calling it TBM doesn't really fit
Can
in.
it be like chronic nutritional anemia superimposed with some underlying already patient was having TBM? Because history is also like irritability and...
Yeah, so see, the point is that chronic nutritional or underlying anemia, yeah, possible, deficiency anemia, possible, but then they don't start with irritability as the first complaint. So when you said iron deficiency causes irritability, yes, they are more cranky compared to normal hemoglobin children. But I don't know whether parent will come to the doctor saying that my child is crying all the time or is this. That is one. And then if it was overall nutritionally poor, malnourished, then there would be other symptoms like diarrhea, etc. So many other.
Sir, case of nutritional anemia with some underlying TBM and deteriorating now.
So case of nutritional anemia not with underlying TBM, underlying TB focus, which has now manifest. That's what you are trying to say.
No, I think that is out of question. The story begins with slowly progressive headache. Don't forget that. TBM doesn't present with slowly progressive headache. Okay. TBM may present without neurological symptoms till the disease starts there. The focus might be there, but once the disease starts, the symptoms are reasonably of a shorter duration. And younger the child, shorter the duration of presentation. 3-year-old child would have presented with drowsiness, seizure, fever, and of course past story of not doing well. Not 3 months of so. So to me TBM is out. Okay. We did discuss that it was a chronic progressive headache. So we said raised ICT without brain parenchyma or cortical symptoms or signs. So we said go out of the brain, but inside the skull. That's how we have progressed. And I called it deficiency anemia because a slow bleed is a deficiency anemia. Okay, hookworm is a deficiency, polyp bleeding is a deficiency. So we called it deficiency. I expect no liver and spleen. Okay, and the cause is a bleeding. So that sickle doesn't come with bleeding. Sickle comes with small vessel obstruction or even a medium-sized result, but an acute onset. Hand, foot, chest syndrome, hemiparesis, but not bleeding and not chronic progressive raised ICT. So that's also not likely. Coagulopathy, we already said, less likely. At 3 years of age, the common cause of coagulopathy, congenital or acquired. Acquired is liver. Okay. Unusual clinical manifestation of a bleeder and then not slowly bleeding of that kind. Okay. So that's malformation. Yes, we may not be able to rule that out, but not malformation in the brain. Outside the brain we are talking about. So,
Go on examination.
So ANC, it was registered pregnancy, iron folic acid supplements taken. 2 USG scan were done. Scan during 6 months, told to have polyhydramnios. History of preeclampsia during pregnancy, and mother was taking medication regularly. Birth-wise, child is full-term. LSCS in view of preeclampsia in mother. Cried immediately after birth. Birth weight of 1.7 kg. History of NICU stay for 2 days in view of low birth weight. Child was discharged on day of life 3 and was on full breastfeed. Immunized till date. Developmentally appropriate for individual milestones. Dietary exclusively breastfeed till 6 months. Complementary feed starts at 6 months of age in the form of Cerelac, which mother used to give 2 to 3 times a day till 9 months. After 9 months, child was started on semi-solid and solid foods. Child eats from 4 out of 7 food groups, and diet is deficient in grains, roots, tubers, legumes, nuts, and fruits and vegetables, and micronutrients. So expected calories are 1016, intake is 500, and there is a deficiency of 561 kilocalorie per day, and a protein deficiency of 2 gram per kg. Socioeconomically belongs to lower socioeconomic class according to KMS. So on examination today, child is examined on day 8 of admission. Child is afebrile, under sedation. Child is intubated in PICU under sedation. Heart rate of 74 per minute. Peripheral pulses well filled. Extremities warm, and blood pressure is 134/78, which is more than 99th centile. Anthro-wise, child is moderate acute malnutrition. Head to toe examination is within normal limit. Systemic examination, child is under sedation. Tone hypotonia in both upper limb and left lower limb. Hypertonia in right lower limb. Power in right upper limb and lower limb is 2/5, 2/5, and left upper limb, lower limb, it's more than 3/5. Reflexes are knee on right side is absent, left side it's +3. Ankle on right and left side is +3. Upper biceps and triceps are +2 in both upper limb and lower limb. There is ill-sustained right ankle clonus. Pupils are bilaterally equal and reactive to light. Sensory examination cannot be checked because child is sedated. CVS, there is S1, S2 present, ejection systolic murmur, loudest in the mitral area, per abdo, soft non-tender, and air entry is bilateral equal and clear. So the provisionally patient is 3-year-old female child, third by birth order, born of non-consanguineous marriage, birth by LACS, developmentally normal, immunized till date, moderate acute malnutrition by anthro. We came with complaints of irritability, fatigability and increased paleness, with severe pallor, presenting with severe anemia in failure, with signs of raised ICT with right hemiplegia, to rule out hematological disorders like hemoglobinopathies, coagulopathies, structural AV malformation, and chronic infective etiologies like TBM.
Go back to your physical findings and analyze each one of them. Go back. Yeah, stay there, stay there.
Yeah.
Next one. Yeah.
No, the other next slide.
Yeah. No, go. Yeah, stay there, stay there. Any comments on this?
So this is a 3-year-old child, right? 3 years.
Birth weight 1.7.
Yeah. So 3-year-old with birth weight 1.7. Now let's talk about weight, height and head circumference. So what is this weight age, as we say? At what age would you expect this weight to be normal? What age normal child would you expect 10.3 kg weight? Very good, 15 months. Okay, means now in a well-nourished, good family it could be 1 year, but in a little less nourished family, or maybe depending on the familial builds, it could be 1.5 years also, right? Now what about the height, 80 centimeters? At what age do you expect 80 normally? Again, so 15 to 18 roughly, okay, normal. Now look at the weight for height. What is that weight for height? And what is it in this child? It is -2 SD to -1 SD, which means what? Huh? Normal or abnormal?
Both are affected.
So now we forget all this and we only talk of SDs first.
So both weight and height are affected equally. Not equally, but not one is not affected significantly compared to the other.
Yeah. So what I mean is, first let's finish the SD understanding. So what do we mean by -1 to -2 SD? Is it normal or abnormal? Forget here, in general. Anything, if I say anything, I say BP, I say fever, I say whatever, is between -1 to -2 SD. Is it normal or abnormal? It is normal. Up to -2 SD is normal, right? So this child's weight for height is normal. Now as you said that it is probably similarly affected. That's what you are trying to say. Now bring in what sir said, 1.7 kg at birth. Okay? Was it full term or preterm?
Full term.
Full term.
So Ayurveda, he has gained 8.5 kilos. Being a Ayurveda and severe Ayurveda, when do you expect a severe Ayurveda of 1.7 kg gain 8.5 kilos? How long will it take? First tell me, how long does it take for a normal child? 8.5 kilos. Come on, this must be not at the tip of your tongue, outside the tip.
gain 8.5.
No,
2 years.
so
6 kilos in the first year, 2.5 kilos every year. Simple. Okay. Same way, 25 centimeter in the first year, 12 centimeter in the second, and thereafter 6, 5.5, whatever. It's so simple. So 8.5 should have taken normal weight child 2 years. This is IOGR. He will be faster or slower. Will he make up? Nature will say, come on, make up. Be in a hurry. Or will he be further slow? Or will he be just going the same way? What do you think?
So he'll grow faster.
Grow faster? Yes?
So you want to first differentiate between IUGRs?
Is IUGR a fetal malnutrition?
No, sir. Maternal.
So fetal
complication.
malnutrition. Does malnourished child grow faster? So preterm AGA would have started making up. This child would not be faster, he would be slower. So normal child would have got 8.5. This fellow has done in 3 years. Fine. Okay. The length, we don't know the birth length. The length would have got ahead of head and the head would have got ahead of length. That is all that we know. So IUGR take time to pick up, and a severe IUGR may not even pick up to adult height, adult weight. Yeah?
Okay, go ahead.
Go the next one. Next one. Yeah. Now, how do you analyze this?
So just give a thought to these signs and tell us what do they mean. First of all, are they symmetrical or asymmetrical?
Asymmetrical.
What is the asymmetry?
So right side there's hypertonia and on the left is hypotonia. And also the power is different on both sides.
How different is the power? So basically all 4 limbs are affected. All 4 limbs have a power that is affected. All 4 limbs have a brisk jerks except maybe right knee which is absent, right? And there is a ill-sustained right ankle clonus. So what would you call this? Would you call this quadriparesis? Would you call this hemiparesis? What would you call this? What do you think?
It's hemiparesis, right-sided hemiparesis.
Speak in the mic. Why do you say right-sided hemiparesis?
So power is 2/5 in right side.
Compared to 3/5 on left side. So is that big enough to call it hemiparesis? Left side is also affected, na? 3/5 is not normal. You are saying 3/5
It's more
or
than 3/5. It's more than 3/5.
means
She is moving left side.
you are saying left side is normal.
Yes.
Huh?
Yes, sir. Huh.
Okay, you are saying left side is normal. And then jerks are brisk even on the left side or only in the lower limbs?
Only in the lower limbs.
Only in the lower limbs jerks are brisk on the left side.
Left side.
Now right knee absent and right ankle clonus, what does that mean? Does it have a neurological significance? So I don't think that is very easy to explain. So it is probably an issue that we just didn't get the right knee jerk rather than trying to say that right knee absent and right ankle clonus.
There's one comment here in the chat box. Dr. Palni Raman again. He was talking about the symmetric IUGR versus asymmetric. He says the symmetric IUGR would make it up. I mean, the symmetric would not make it up, whereas the asymmetric will make it up.
Yeah.
And also a little bit on, this is not from Palni Raman, on whether scurvy could cause irritability in a 3-year-old. And the second one was scurvy, and the other one is the late hemorrhagic disease. This child has been an NICU graduate, must have received some antibiotic. Could you have such a presentation?
But as late as 3
No,
years.
the irritability, not the catastrophic one, but the late presentation. Can it be so late?
I think first thing is clinical manifest scurvy is extremely rare. And I bet almost you must have never seen one. Not that it doesn't expire. It is seen only in a very severely malnourished child who has been vitamin C 0 intake for more than 6 months. You need 0 intake of vitamin C for more than 6 months to get a first symptom of irritability, etc. Then the manifestations can go on for a very long time, missed, because these are very severely malnourished children. What I want to say is that scurvy is unlike rickets or iron deficiency. It's not seen in a healthy children. It's seen in a malnourished and a severely malnourished children. So there are many other symptoms. So looks unlikely, but yes, somebody is giving a right thought process that scurvy could be a bleeding manifestation. Okay, and I think well taken. Same thing, vitamin K. Now the question is, must have been on antibiotic, so further depletion of vitamin K. Even regularly given antibiotic again and again is rarely a cause of significant bleeding, though I know that the vitamin K is suppressed, but not to that extent. Okay, unlike a malabsorption, where you cannot just get absorption at all, might have such a thing, but even that is late because there are many other symptoms preceding that probability. So here that's not likely.
Sir, your findings?
Yeah, all that she means is there is some right hemiparesis as compared to left, the power is less. Okay, and she also says that the jerks are a little more brisk as compared to the other side, which might favor whether there is some upper motor neuron lesion on the right side. And ill-sustained clonus does not mean upper motor neuron sign. We haven't seen the plantar. Okay, but the child is already sedated, so your analysis might be, evaluation may be little difficult to go by. What bothers me is that there is a hypertonia in the right lower limb, but hypotonia in the right upper limb. Okay, so if you call it a hemiparesis, then there is a discrepancy between the tone. Are we looking at something that worsens suddenly and therefore temporarily the signs are different, which is likely, but not the signs related to original description that we anticipated. After all, this child suddenly crashed, so there must be many signs that must have changed, and you might, there is no way to clearly put this to an anatomical localization. Okay.
So again, there is a comment from Dr. Sakshi Buddhi, who says that as the child is sedated, could you have a bias in the assessment of neurological signs?
Absolutely, yes, yes. And that's what I'm saying, that if we had seen this child before he crashed, the signs could have been some way different, and there could have been an upper motor neuron, and it could be patchy, because we are looking at a mass coming from outside and pushing the brain. It is not a typical middle cerebral artery dense hemiparesis. It has to be some atypical one, where one limb is more involved than another. That is acceptable, but these changes are possibly due to the sudden crash and a child becoming that's the only way we can go by. Right. But sensory cannot be checked. Yes, that's all right. What about that murmur there? It's a cardiac disease, and therefore it's a complication of bleeding in a cardiac disease. Okay, it's a subacute bacterial endocarditis.
What do you think?
Do you think it's pathological or not?
It could be a hemic murmur because she is anemic also.
But it may as well be also pathological. Okay, you're right.
So is anything there in the nature of the murmur which tells you? What is the description of the murmur?
Ejection system.
So what does ejection systolic mean? Does it have a specific meaning, ejection systolic? So ejection systolic is usually a discrepancy between the size of the valve and the flow through the valve. So either the size is small or the flow is more, right? So here you know that this child is very pale and has been transfused and all. So it is a hyperdynamic circulation. So more flow is a possible this thing, right? Okay, go on.
So we worked up child.
Speak in the mic properly.
Sir, the investigation on presentation. So the HB on presentation was 1.2 with MCV of 67, MCH of 14.6, MCHC of 21.8, WBC count of 5.1 K and platelet of 28,000. So we give 3 PRC transfusion on HB of 1.2. Anemia workup में PS suggestive of hypochromia with anisocytosis, 5% metamyelocytes. Retic count is 0.5% and corrected retic count is 0.05%. DCT, ICT is negative.
Stop. Go back. So what does this mean?
Marrow function is affected.
Why do you say
Retic
that?
count is very low, 0.5%. And metamyelocytes are there. Something infiltrative marrow. That is.
So it suggests that there could be infiltration of the marrow, but what is against? So suppose you don't look at the lower part, you only look at the indices. What do they tell you?
WBC is not affected.
Okay, so WBC not affected. You would like to know the differential breakup
Yes.
of that 5,000 as to how many neutrophils,
Neutral
etc.
and lymphoma.
But what do the indices tell you?
Hypomycemia.
What are these indices indicative of?
Hypochromic anemia.
Yeah, so hypochromic microcytic. Marrow diseases are characterized by what kind of anemia? Marrow infiltration.
Normocytic.
Normocytic. So not hypochromic and microcytic, right? So
But
that
then some nutritional cause could be associated with it,
like
which is nutritional deficiencies. So that could cause the microcytic.
so you're saying nutritional deficiency and a marrow problem.
So
and
if
a
you
new
get
onset marrow
if you get a thalassemia who has 1.2, would you say it is a nutritional plus thalassemia? No. Why two diagnoses in the same anemia? No. That is not right. And therefore, this is a chronic deficiency anemia. That's what we said. The cause may not be nutritional, but it's a chronic deficiency anemia. Okay. But platelets are low, right? So why are platelets low?
So because it's a microcytic picture,
No, there
then it would be the other.
high. Yeah, microcytic leads to a high platelet count erroneous. So platelet low is a surprise that there is something wrong there, and that very poor retic count is also a surprise, but we'll have to see how we can explain that.
Generally, when there is a bleed like that, platelet should have gone up. Okay. So, but this could be a worsening of an acute onset we have no idea what all things really happened at that time. The child could not be brought because child is in an ICU. He suddenly crashed. But these are, all that we know is that it's more likely a deficiency on this picture, right?
So serum iron is 21, vitamin B12 is 874, which is within normal limit. Initially we did 2D echo, which was suggestive of GLVH with ejection fraction of 45%.
What is GLVH?
So global left ventricular hypokinesia.
Hypokinesia.
After child crashes, we did CT brain immediately, which was provisionally suggestive of NAD. LP suggestive of total 4 cells out of 3 lympho, protein of 20 and sugar of 47. Fundus examination was NAD. So child was immediately shifted to PICU. In PICU, child was having persistent high BP readings with bradycardia with signs of raised ICT. She developed sudden onset paucity of movements in both right upper limb and lower limb. Repeat CT brain, because she developed new onset of paucity of movements, we did repeat CT brain, which was suggestive of age inappropriate cerebral atrophy with prominent lateral and third ventricle. There was no evidence of periventricular ooze. Child was posted for MRI brain and MRI is done. Provisionally it suggestive of IC bleed with midline shift of 7 mm. Final report is pending.
How is the child now?
Actually, sensorium-wise, child is improving now. Child is improving now. We are giving measures for raised ICT. Otherwise, child is still intubated. Recipe-wise, he was already always good.
So how do you assess the fundus?
Actually, sir, papilledema.
Raised ICD. So is it with a fundoscope or you use an ultrasound?
No, sir, with fundoscope by ophthalmologist.
Because that takes a lot of time. So now we use the ultrasound called focus, and we measure the optic nerve sheath. So that's done immediately as soon as the child is wheeled into the PICU. That's an easy way of doing things. You don't even have to dilate, or you can assess the pupils as well as you do an ultrasound, focus, and on the spot you get to know that. So what is the cause for the hypokinetic left ventricle?
Sir, as a child come with HB of 1.2 and there were signs of failure. When child on arrival, child was very tachycardic with heart rate was 180 and a liver of 4 centimeter. So she was in failure. So the hypokinesia is due to anemia in failure. Actually, sir, we did repeat 2D echo, which is now suggestive of ejection fraction of 60%.
Operator dependent.
So this 2D echo was on admission?
No, this was on admission.
Even before the transfusion was given?
Yes, sir.
Okay.
I think this child could have a hepatomegaly because this child is so slowly progressive, very severe chronic anemia, and therefore there could be a congested liver. This child may be in a CCF also. Okay, so that doesn't worry me and that doesn't put me to a liver disease. Same thing about the ejection fraction, etc., that after all there is a slowly progressive severe anemia and therefore the myocardium is not working at its best. So even that is acceptable. But those things don't bring in a primary problem somewhere else other than what we are saying. So I think we are seeing a child who crashed, who had chronic progressive problem, and therefore with a severe anemia of 1.2 gram, there could be every other organ already affecting. And the heart has taken a brunt, the liver has taken a brunt, yes. That doesn't push us to find a primary cause somewhere beyond what we have discussed. What is more important is, whenever in a general hospital you do an urgent CT, the person who is interpreting urgent CT is also junior. Therefore, there is a lot of difference in the, and he said provisionally normal, but he has used the word right. Provisionally, he would possibly give an impression after consulting one of his seniors or whatever. And I think this does happen. So, ultimately, you required MRI. But to me, one would not have missed totally the CT report. Okay, but it's likely, after all, like you are all still learning, and don't forget, we are also still learning. So we make mistakes. That is all right. Okay, that's why those discrepancy, but we don't have to start asking which neurological bleed has normal in CT and abnormal so much in MRI. No, that is unlikely, right?
So now retrospectively, apparently the imaging has found a bleed only intracranial with midline shift. So this seems to be only the acute deterioration that has happened, right? So now it brings us back to our original history. So this is where probably the art of history taking comes in. That, see, sometimes for parents, how do they say irritability? They say radat rato kya rote rehta hai. So then we have to get into the depth of that history and ask what exactly do they mean, how much of the time does the child play versus how much of the time the child cries. So all children cry little bit here and there, but if that irritability is projected as a chief complaint, then you start thinking differently, right? So here apparently now, after you have given us everything, the bleed is intracranial, which happened after admission, and probably because of that 28,000 platelet count, we don't know. So now what remains unexplained is why the 28,000 platelet count, why that hypertension that you are talking of. It is more than 99th, no? 134 by
77.
Yeah, it's higher. So why that hypertension, we don't know. And yeah, so anemia, even if we call it whatever, nutritional, etc., two things are still unexplained. So any discussion at on your side as to what is the cause of hypertension?
Sir, we are thinking of hypertension is due to raised ICT only.
Okay. And you said bradycardia, so what is the heart rate? You had said 76. So is 76 bradycardia for this child? Or it
Yes.
goes lower?
It goes lower. It goes up to 65 and 64.
Okay. So that, I mean, as Palni put it, whether the medullary pontine centers are getting affected and that is causing the hypertension and bradycardia, I don't know.
The renal parameters are normal?
Yes, sir. RFTs are always normal. We haven't done renal Doppler yet.
Okay. And that LDH reading, what was the normal range in that lab where it was done? Some 700 and odd you gave.
704 LDH.
So, no, I'm just thinking back when when you can't find anything, you try to look at whatever is abnormal.
Okay. Anything from the chat, Sridhar? Any other questions or anything?
I think one is certain that this is just not an intraparenchymal bleed alone. Well, you have seen it at the fag end of the story, but any parenchymal bleed would have presented with the symptoms of a brain parenchyma, and classically a seizure, or if it's extensive, then much more. This child just started with raised ICT, and that puts me to say still that we did start with something which was not parenchymal. And thereafter, some seizure, and then thereafter some worsening, then hypertension, all that. Though hypertension looks very, very severe to do that. Is blood pressure still remaining high?
Yes, sir. Signs of raised ICT are still there.
Signs of raised ICP are still there.
Like bradycardia and raised ICT.
No. So,
Sorry, hypertension.
correct. But now that you are ventilating the child, I don't think the ICP should still be raised.
That's right.
So your signs are now not signs of raised ICP. The bradycardia and hypertension seem to be of some other origin.
There's no iatrogenic cause. Must be pumping in steroids.
No, sir. We are giving steroid for cerebral edema part.
That's what I'm trying to say.
Something funny. Okay. In fact, a secondary hypertension that we are talking about, secondary to raised ICT, is a small time, rare, at the fag end, and it should be, if the child is improving, the blood pressure should come down. Okay. It's a primary hypertension, renal or whatever, which is difficult to control. But this should not be. So I think it could be drug induced, as you said. That might be the cause. Okay. Anyway, that's quite interesting because we are looking at a child before he worsened, and now we are looking at a child after he worsened. Certainly, our impressions gathered prior to worsening were a slow onset bleeding and deficiency anemia, which looks reasonably right. But the MRI shows now intracranial bleed, which must be something that has happened later in the course. And as we said, hypertension could have been also worsened by the steroid, because you don't get that kind of hypertension, as we said, in the raised ICT. It's just a borderline hypertension, and it should have come down by that. Anyway, I think these are the kinds of things. What is more important is how do you kind of defend your opinion on the present issues. And I think that is where, in a medicine, we are always stuck up at some place where some finding does not correlate, some investigation does not correlate. That's fine. We would learn why it did not correlate, but still, our thinking remains the same as we started looking at, right? Yeah.
Any questions from you all?
Sir, in this scenario, will the steroids help or worsen if now that the MRI is showing a bleed?
So my question to you is, which cerebral edema steroid is the drug to use?
So if there's a intracranial space of malignancy or there's cerebral edema surrounding a mass.
No, let me tell you how to go about. Cerebral edema is either vasogenic, okay, or cytotoxic, or interstitial. Okay. Which type of cerebral edema are we giving steroids? That is the question. The cause may be whatever. So is it a vasogenic or a cytogenic or an interstitial?
Think of models of each cerebral.
Yes. If it's a vasogenic, that's the place where you would use steroid. If it's cytogenic, cytotoxic, you would use probably mannitol, but not a drug of choice today. You can use saline or whatever. Okay. And if it's an interstitial, then possibly a diuretic. Okay. So this is the way we would look at this kind of a cerebral edema. So I suppose if steroids are given in a higher dose for a long time, and acute hypertension is likely.
Any other question?
Cause of anemia in this child. HPLC not this time.
HPLC is normal.
Is normal?
Oh, yeah.
Okay.
Actually, sickling test is also normal.
I think by next Thursday, we would like to know what has happened to this child, because we need to learn more and more and think more and more where we could have improved on our thinking process or discussion, etc. Right? And I think please make a point next time to tell us what has happened, what kind of treatment was received, how did the child improve, all that, which might make us know where we missed something, but this is the maximum way we could have gone by, right?
Okay. Thank you, and we thank all our online viewers and the faculty online for giving their valuable inputs. We meet once again on next Thursday, that is 9th of February at 6 p.m. Thank you very much.